Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream. Today's live stream is about 5 reasons why families in intensive care have the perception that ICU teams want to stop treatment prematurely. Now, before we go into today's topic, just some housekeeping issues. I also want to welcome anyone that's watching this on replay who doesn't have the time to make it live here. We always get a lot of views on replay, but this is your opportunity to come on live on the show and ask questions to me directly, and I can answer them straight away. We will be going for approximately an hour. I will talk about the 5 reasons why families in intensive care have the perception that ICU teams want to stop treatment prematurely, and then I will have other questions that we get during the week to go through. There's plenty of things to talk about when it comes to pain points for families in intensive care, which is why I'm making these live streams and many other videos, because we get so many questions and insights from families in intensive care, and we provide a safe place here to answer those questions. So before I go into the 5 reasons, what makes me qualified to talk about topics for families in intensive care? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and where I've been consulting and advocating for families in intensive care all around the world since 2013 here at intensivecarehotline.com. And I can very confidently say that we have saved many lives with our consulting and advocacy, and you can verify that on our testimonial section at intensivecarehotline.com, and you can also verify it on our intensivecarehotline.com podcast section, where we have done client interviews, once again, who verify the work that we've done for them, saving their loved ones' lives. So I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies. And we do that all around Australia at the moment. We are the only service in Australia that is actually third-party accredited when it comes to intensive care at home nursing, which once again includes ventilation, tracheostomy for adults and children, BiPAP, CPAP ventilation, tracheostomy care, home TPN, etc. We also provide level 2 and level 3 NDI support coordination at Intensive Care at Home, and you can find out more information at intensivecareathome.com. Okay, without further ado, let's talk about the 5 reasons why families in intensive care have the perception that intensive care teams want to stop treatment prematurely on their critically ill loved one. So, the video today comes out of talking to hundreds, probably thousands of families in intensive care over the years, in 2.5 decades worth of intensive care nursing experience, and also intensive care at home nursing experience, right? And that's the perception a lot of families have. And, I made a video the other day with the title, "What's the urgency in killing someone in intensive care?" But that is actually, that's a title that came from one of the families that reached out to us and asking that very question. That was exactly their perception that they had. And certainly when I worked in intensive care still actively, right, I was certainly having the perception that there seems to be a rush to prematurely withdraw treatment whenever timelines of responsiveness to treatment wasn't met, right? So what that means is, if intensive care teams think that, recovery is not happening in a time frame that's convenient for intensive care team, then the clock is ticking, right? The clock is ticking down, and then families get told, well, we should be withdrawing treatment, because if your loved one is going to survive, they won't be having any quote unquote quality of life. Well, what's quality of life? It's a perception, no more than that. It's a perception, no more than that. It's not reality. It's a perception. And intensive care teams are extremely bad at predicting the quality of life of a patient who survives intensive care. They're extremely bad at that, right? So next. But let's dive into the 5 reasons why families in intensive care think that intensive care teams want to stop treatment prematurely for their loved ones in intensive care. Now, these are the things that I've observed over the many years and decades that I've worked in this space, right? Number 1, and that is to me the most important point, is that intensive care teams want to stay in control of the narrative, right? And they want to stay in control of a negative narrative. And why is that? They want to stay in control of a negative narrative to protect, what they can do, to stay in control of the interaction. So picture this. You have a family member in intensive care for whatever reason, and the intensive care team tells you, oh yeah, we'll be doing X, Y, and Z. And then, in 3 days or in 3 weeks, whatever the time frame might be, your loved one will be discharged out of intensive care and off they go to rehabilitation or recovery, right? And then it doesn't happen. The doctors and nurses could potentially be liable. So it's a liability issue, right? So therefore, they tend to underpromise. If anything, they tend to talk about end of life early on. Now, with all of that said, when a patient is in intensive care, they are very close to death compared to other situations, of course. They're probably as close to death as they've ever been, right? So there's certainly some context to that. By the same token, it is all about protecting the downside, and it's part of their training, right? So you have to read between the lines. Just because they're putting a negative narrative out to you doesn't mean everything is doom and gloom. Not at all. That's why you need to get a second opinion from day one. That's why you need to have someone hand-holding you through this once-in-a-lifetime situation when you have a loved one critically ill in intensive care, and you simply can't afford to get that wrong. Because if you do get it wrong, that's when intensive care teams might withdraw life support prematurely without advocacy, without you getting a second opinion, right? So the next reason, and it's much easier for them, let's just say things improve, okay, and the loved one is on their way to recovery and everything is well. It's much easier for them to say, oh, okay, we were wrong. Things have improved. Great. Right? But by creating a negative narrative right from the start makes it very easy for them to tell you, well, I told you so. I told you so right from the start. Right? Makes it much easier for them to go down the track of, well, I told you right from the start we should be withdrawing treatment. Makes it much easier for them to stay in control of the narrative. Right? Next. They are protecting their downside. Ties right in with the first case that, health and intensive care in particular can be a very litigious arena, right? Many lawsuits might follow treatment in intensive care. And once again, by them saying, well, it's not going to look great, we should be stopping treatment here very early on, so your loved one is not going to, quote unquote, suffer, once again, protects their downside, protects them from telling you the opposite, which would be, once again, let me repeat that because I think it's so important. They're not telling you, oh yeah, we'll do X, Y, and Z treatment here, right? And then your loved one will leave intensive care alive. That would be one way to approach it. And then if it doesn't happen, you could sue them. By them telling you, oh yeah, your loved one isn't going to survive this, and your loved one isn't going to survive this. And then if they do, it's much easier for them to say nothing. But if things go from bad to worse, they can easily tell you, well, we told you so, right? So you have to read between the lines. You absolutely have to read between the lines. Number 3, they want to manage beds and staff and equipment, and they want to stay in control of that. So what do I mean by that? The most sought after bed in a hospital is the intensive care bed, the critical care bed, That is the most sought after bed and most in-demand bed in a hospital or in an ICU, right? So, with that said, right, if there's pressure on beds and they need beds, one way to manage beds is simply, by saying, look, we should be stopping treatment here. Your loved one won't survive. They won't have any quality of life if they do survive. And, let's stop treatment. That I have seen hundreds of times in intensive care. And I didn't realize it at the time when I was working there, right, that this is what's actually happening. Because especially with services like now, intensive care at home, for example, you can take patients home and continue treatment at home, improve quality of life at home, improve quality of end of life at home, right? So, they want to manage the resources, and that's another reason. So I'll give you a tangible example here. I remember many years ago, when I was still full-time employed in an ICU as a critical care nurse, I was coming on to a night shift. And I remember it was a 60-something-year-old man after he fell off his roof. He was doing some work on his house. He fell off his roof and he banged his head on the ground. And he ended up with a traumatic brain injury. And, his brain was severely, severely damaged, right? And he was declared brain dead, right? Gone through all the testing and he was declared brain dead. Now, in most jurisdictions, when someone is declared brain dead, they are also legally dead, right? That's just the law. Well, explain that to a family who's in shock, who is going through bereavement, who, has no idea what's happening. What does it even mean when someone is brain dead, that they're legally dead? Explain that to a family emotionally, who's in emotional distress, right? You can't really explain that to them, right? So what that means is, and then when I came on the shift, when I came on the shift, I was told, well, you need to extubate this patient by 10 o'clock tonight. We're just going to stop everything. And I said, no, I'm not, because the family is not ready. I knew that instinctively, right? And I was told, well, are you going to not follow orders? And I said, that's exactly what I'm doing. I'm not going to follow orders. I said to the doctor at the time, if you want to extubate this patient at 10 p.m., go for your life. I'm not going to do it because I'd rather go home. And those were my words. And I had the family on my side, right? There was no way I was going to do that. Felt very wrong. And after much back and forth, they agreed with me, also knowing that I meant that I would go home and not continue my shift. And, and I bought the family time. That's all they wanted. It's not that families don't understand when their loved ones are dying, because it was inevitable in this situation. It was a real end-of-life situation versus perceived end-of-life situation, right? That was a real end-of-life situation. But it's about how we go about it, and many ICUs these days have completely sold out and lost their morals and ethics, right? Not all of them. There's a lot of good things happening in ICU, but there's also many ICUs who are simply desensitized, right? They're desensitized by the work they're doing. They're desensitized to patients' and families' emotions, feelings, how we need to approach those very sensitive topics with families and give them the time they need to grieve and go through the bereavement. And there's probably never enough time. But the more time, the better. And I know at the time what happened. I think it was on a Sunday night, actually. And I remember there were lots of cases coming in the next day. So the ICU was under a lot of pressure, freeing up the beds. But we can't just free up beds by killing people, right? That's just not on, And also there's a shortage of ICU staff, doctors, nurses, physios, whatever the case may be, right? And that inevitably beckons the question, how do we treat those people when they're working in ICU? Are we treating them well enough so they actually stick around for a long time to come? That's a whole separate discussion, right? But you understand what I'm saying here. So then, what other reasons are there to why ICU teams, 5 reasons why families in ICU have the perception that ICU teams want to stop treatment prematurely? Well, another reason that I believe is happening, it's clearly undermining patient rights, and it's also undermining family rights, and it's undermining human rights. And I think we are in an era now where, you know, human rights and basic human rights are trying to be undermined, especially with this woke narrative going on everywhere. That, in my mind and from my perspective, is clearly trying to undermine human rights, you know, trying to limit free speech and so forth, right? Case in point, last week I was in a family meeting with one of our clients in an ICU in the US. Well, I was there through a video call, right? And the ICU is trying to withhold nutrition from a patient. Now, nutrition in critical care is incredibly important. There's enough research out there to warrant that nutrition is absolutely inevitable to be given for a critical care patient, right? It helps with healing, it helps with recovery and so forth. There's enough research out there. This man hasn't had any nutrition for 5 days, right? That is negligence. That is starvation. I go as far as it's an attempt of euthanasia, potentially an attempt of murder, could be perceived as that, right? And I was calling them out. I said, by you not giving nutrition, you're denying a basic human right, and you are potentially attempting to kill this person. We can't live without nutrition. And it was about the argument around whether the patient should have TPN or a jejunostomy tube. And the reason for that is the patient is BiPAP dependent. If you feed them through a nasogastric tube or a PEG tube, they're at high risk of aspiration, right? So the other alternative here is TPN. TPN needs a central line insertion or a PEG line insertion, right? And then the intensive care team told the family that it's too high infection risk to do a PEG line, central line, Hickman's line for TPN, right? Now, my response to that is, that's like saying we should stop eating and drinking in case food is contaminated, right? So ICU says we can't do TPN because of infection risk. Yes, there's a higher infection risk for TPN than there is, for example, for feed through a nasogastric tube or a PEG tube. No doubt, right? No doubt about that. However, once again, that is like saying we stop feeding, we stop eating and drinking because food might be and food and drinks might be contaminated. That's ludicrous, right? That is absolutely ludicrous. So, you know, it's an undermining of patient and human rights, clearly, right? And ICUs want to stay in control of that. They want to tell you that it's human to kill someone because they're suffering and they won't have any quality of life in the future. Well, as far as I'm concerned, life is sacred, right? Life is sacred. And when I worked in ICU still, in the end, I turned, you know, it sort of opened my eyes eventually that there's actually euthanasia happening in ICU, but nobody wants to call it that way. If you start morphine and midazolam to help someone in the process of dying, that is euthanasia as far as I'm concerned, right? And we need to open our eyes to practices, right? We need to open our eyes. Now, so it's undermining patient and human rights, and we need to open our eyes. Now, what they also did this week when I was in the family meeting as an advocate, they told me that we should have a civil conversation around what's happening. And I said, well, let's not use euphemisms here. You are trying to kill a patient by starving them. And that's what I mean. You know, people want to restrict what people can say in this arena, right? Well, it's time to call people out for when they're doing the wrong things, we need to call people out for when they're doing the wrong things. And what I also mean by that is they are, they've lost all morals and ethics. They're desensitized. For them, it's Mr. Smith in bed 5, he's on BiPAP, he's got a critical illness, and that's it. They're not looking at that it's someone's dad, someone's husband, someone's grandfather, whatever the case may be. For them, it's just, yep, Mr. Smith in bed 5, he's on BiPAP, he's dying perceptionally, right? Because you can keep people alive for a long time if you want to, right? With the right mindset, with the right resources. Once again, that's why we have a business called Intensive Care at Home, where we send patients, adults and children, home from ICU, predominantly for long-term ventilation and tracheostomy. But, ask our clients, ask their families, do they think they're suffering? No, they're not. They want to live. So this whole notion of, well, we don't think that this person will have any quality of life if they do survive, is complete and utter nonsense, right? Ask the patients and families what they want. Why did Stephen Hawkins live into his 70s on M&D on a ventilator with a tracheostomy if he didn't have any so-called quality of life, right? You got to look what's happening in the real world. And you got to open your eyes to it, right? And lastly, the fifth reason why I believe that families think in intensive care that intensive care teams are withdrawing treatment or stopping treatment prematurely, I do believe we have is population control. I do believe we have moved into an era where governments, health services try to control the population, right? And by deciding who can live and who can die and when, we have an element of population control. That, in my eyes, is particularly visible in the UK, right? If you look at what's happening in the UK, but it's also happening in the US, Australia, but in the UK in particular, where the courts are giving free rein to the NHS to kill children in ICU, right? Latest cases were Alfie Evans, Charlie Gard, Archie Battersby, and there were others as well. Alma Hicks, I think. There were others too, right? Look at those cases, right? They want to decide who can live and die, even though those kids could have ongoing treatment in other countries. The UK courts wouldn't even let them fly out to other countries, right? That, in my mind, is population control. And they didn't want, that kids can live because their parents are advocating for them, right? So it's wrong. It's wrong on all ends. Okay, next. So those are the 5 reasons, right? What do you think? What do you think are reasons? Leave your comments. Leave your comments, or join me live now on the StreamYard link if you like, and share your opinion. You can join me live here on the StreamYard link by clicking on that link here. You can talk to me directly. You don't need to go on camera, but you can go on camera. Or type your questions into the chat pad and I will respond to them, right? Also, there was a documentary from NBC News in the US last year. It's an interesting documentary and you must watch it. You must absolutely watch this documentary because journalists have done some research that some hospitals in the US get incentivized by moving people into palliative care and into hospice and letting them die. They get incentivized by health insurances. Let me repeat that. Hospitals are getting incentivized by health insurances to let patients die in either hospice or palliative care. It's getting better than that. And then those numbers of palliative care patients don't even show up in the mortality rate of hospitals, right? It is bizarre, bizarre beyond words, right? So I could probably list another 5 reasons, but I think you get the gist here. You are getting the gist here of what's really happening in this world, and you got to keep your eyes open. You absolutely have to keep your eyes open. Now, what's the remedy here? Well, I can tell you what the remedy is. The remedy is really advocacy. You know, like I said in the beginning, we have saved many lives for our clients and their families in intensive care in situations where, you know, ICUs come to families and say, look, tomorrow at 3 o'clock, we're going to stop life support for your loved one, and come hail, rain or shine. And we have saved many lives in those situations because the ICU can't really do that. Right? So there's ways out of it, but it has to be approached the right way. You often even don't need a lawyer. In some cases, we have engaged a lawyer, but you often even don't need one. Okay, so think about that. Think about that, you know, what's really happening in this world. And once again, I would appreciate your comments, or if you want to join me here and talk about what your experience is, I would be very interested in that, right? But also know that there's ways out of the situation with the right help, with a second opinion, right? The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care, right? That is exactly what families are up against in situations like that, right? So let's then get on to other topics from during the week. You know, what else has been happening this week? I mean, I've got so many questions that have come in, but let's start with one of our clients, and I'm not going to mention names here. Interestingly enough, you know, we're working with a member currently who has their loved one in intensive care. Initially, you know, he had a cardiac arrest and wasn't waking up. And after sort of, again, early on, the ICU team wanted to stop treatment on this gentleman, a 63-year-old gentleman, right? And initially I said to the family, do not give consent to a tracheostomy, because after the ICU team noticed or realized that the family is nowhere near ready to withdraw treatment and that they will have every measure done, right? The intensive care team then very quickly moved towards, well, then we should be doing a tracheostomy. But then again, when we looked at medical records, we thought, well, it's even too early for a tracheostomy. What you always need to ask in a situation like that is, what are they doing to avoid the tracheostomy? That should be your biggest question. What are they doing to move your family member, you know, to wean them off the ventilator and the breathing tube and avoid the tracheostomy? That should be the number one question you should be asking. You should be carefully listening of what they're saying, right? And then we found they were doing absolutely nothing. They were just keeping them sedated, more or less gearing them up for a tracheostomy, right? Then he had a tracheostomy, and then when the family circled back, they said, oh, we already regretted it. Few days after a tracheostomy, and they didn't give consent to a PEG tube, right? Don't give consent to a PEG tube, right? I've said it many times here on this podcast. Do not give consent to a PEG tube. There are exceptions to this rule, and the exceptions are around neuromuscular conditions, you know, spinal injuries. There are exceptions to that rule, but generally speaking, don't give consent to a PEG tube, right? And then after they've done the tracheostomy, without any attempts to wean off the patient off the ventilator, because that is the goal of a tracheostomy, stop sedation, get patients out of an induced coma, and start weaning, right? And the intensive care team did nothing to wean them. The next narrative they were trying to create was, well, now your husband should go to LTAC. LTAC stands for long-term acute care, right? And is basically not even the better version of a nursing home in the US, right? So the family was, you know, they were trying to coerce the family to send their husband into LTAC while they were still being sedated, right? a clear violation of intensive care standards, right? Of best intensive care standards and practices, right? So it is really important that you do your own research. It is really important that you get a second opinion, because otherwise your loved one is probably not getting best care and treatment, right? So what happened from there, and I'll read that out to you. I just quickly need to bring up my notes there. Unresponsive, intubated on mechanical ventilation via tracheostomy with FiO2 100%, that's 100% of oxygen on the ventilator, on continuous renal replacement therapy, which means the patient is in kidney failure, needing kidney support with either dialysis or hemofiltration. Multi-process has support of norepinephrine, vasopressin, intravenous fluids of dextrose 5%, plan to change to normal saline, fentanyl 1.5 mics per kilo per hour, heparin, propofol, amiodarone. Amiodarone is usually given for atrial fibrillation. This gentleman went into cardiac arrest having had a history of atrial fibrillation, right? Also has MRSA, right? And he's on antibiotics such as Zosyn or vancomycin, right? So, and the intensive care team wanted to have a discussion with the family earlier in the week, to send the patient to LTAC. Now, this gentleman is on 100% of oxygen, on 100% of FiO2, right? And room air, the air that you and I breathe in, is having 21% of oxygen, right? So, and now he's on vasopressors, right? He's still sedated and ventilated, right? And once again, one of the indications to do a tracheostomy is to wean someone off sedation, take someone off sedation and opiates as quickly as possible, which didn't happen in this situation. Now, supposedly, this gentleman is breathing against the ventilator, so it's not synchronizing with the ventilator, right? He's probably not there yet because he's got a hypoxic brain injury, right? And dialysis is on, and the nephrology doctor advised strict intake and output to assess renal recovery, daily monitoring of renal functions, renal dose medications, fluid balance, and avoiding nephrotoxic medications. Well, that's all common sense, and that's why this gentleman is in ICU, but there's no way that he could be managed in an LTAC. No way, right? Also with heparin infusion still going on, amiodarone infusion, vasopressor medications. I mean, this is absolute insanity to even talk about LTAC in a situation like that. And LTAC, from my extensive experience, is not even the beta version of a nursing home, right? It is not even the beta version of a nursing home, right? So you absolutely have to get a second opinion when you have a loved one in intensive care. This family would have run blindly towards the fire, would have had treatment withdrawn without a second opinion. Now their family member will get a second chance. Now, there's no guarantee, of course, that patients will survive. Of course not. But at least they're having a chance. If you stop treatment, you know the outcome. If someone is dying, you know the outcome. If you're not stopping treatment and you keep going, you don't know the outcome, but at least you give patients a chance, right? So I hope that sheds some light on this particular situation, right? Let's look at other situations that came in during the week. I also want to talk about intensive care at home here, and want to talk more about conditions that can be looked after, because that's a regular question we're getting. What conditions can be looked after at home with intensive care at home? And I want to read out a discharge summary from one of our clients. I just quickly need to bring up the discharge summary. Just give me 1 second. But in the meantime, if you have any questions or insights that you want to share, if you want to talk to me directly here, please jump on the StreamYard link. Now, here it is, discharge summary. ICU timeline. 74-year-old female admitted on the 31st of August 2024 with past medical history of aneurysmal subarachnoid hemorrhage, hypothyroidism, lupus, CABG, non-Hodgkin's lymphoma, hypertension, chronic kidney disease, who presented to ED with seizure-like activity. Patient family given her 4 milligrams of lorazepam inadvertently, although 2 milligrams of lorazepam was prescribed, which resulted in respiratory arrest and patient transferred to emergency department requiring bag mask ventilation. Reportedly, patient had been recommended hospice care at another hospital, but it has not been established, as family would want to continue with her management at home with home health. She has an extensive neurological history in another hospital where she was initially admitted in March 24, including subarachnoid hemorrhage secondary to right MCA aneurysm and VP shunt placement. The patient was discharged to inpatient rehabilitation and presented back in July 2024 for sepsis and malfunctioning VP shunt, which was reportedly removed. However, it is visible on current CT scan. Patient developed subdural hematoma requiring surgical evacuation. On August the 9th, patient experienced generalized tonic-clonic seizures and was admitted to ICU for a couple of weeks. She was discharged 3 days prior to current presentation on brivaracetam, Dipacode, and Vimpat, but she was not able to fill the prescription for brivaracetam. Presented back to another ICU on the 31st of August requiring ventilation support. Anti-seizure medication adjusted with continuous EEG currently off. Tested positive for C. diff. Adequate treatment. Then VP shunt secondary to prior intracranial insult seizures followed by pneumonia process, which was adequately treated. Her seizure has been adequately controlled with multiple anti-seizure regimen as above. Repeat chest X-ray on the 1st of October showed no acute cardiopulmonary process. She's able to successfully wean off the ventilator support as of the 2nd of October, but she still has a tracheostomy, stable for discharge on the 14th of October. Active hospital problems, diagnosis, palliative care encounter, medically complex patients, advanced care planning is in place. Acute and chronic respiratory failure with tracheostomy, seizures, history of subarachnoid hemorrhage, chronic atherosclerotic disease, hypothyroidism, and C. diff. Now, care plan is, all discharge education and documentation completed, ABS summary printed and reviewed with patient, caregiver, and intensive care at home, and sent home with 24-hour intensive care nurses. All questions from patient family addressed prior to discharge. All belongings, supplies, and educational materials sent with patient family and provider. So, I really hope you understand now what's possible, right? So just because someone is medically complex doesn't mean they can't leave intensive care, not at all, right? So please keep all of that in mind, right? So that's one, gives you more insights in what can be looked after at home with intensive care at home, right? So let's look at another patient that can be looked after at home, because we're getting more and more inquiries, what patients can you look after with intensive care at home? Now I just need to look up another medical summary. I just need to bring it up on my phone. Just give me 1 second. And in the meantime, if you have any questions, type them into the chat pad. Or if you want to talk to me and have your questions answered here, just join me live on the StreamYard link here. And you can talk to me directly here. Here it is. Okay. Another condition that can be looked after at home is 22-year-old young man, acute on chronic respiratory failure with hypercapnia. Hypercapnia means high CO2, high carbon dioxide, acute and chronic respiratory failure with hypoxia, pneumonia, unspecified organism, bradycardia, unspecified, dysphagia, oropharyngeal phase, anoxic brain damage, not elsewhere classified, pressure ulcer of the sacral region, unspecified, encephalopathy, unspecified, unspecified, convulsions and seizures, quadriplegia, unspecified, neuromuscular dysfunction in bladder, unspecified, critical illness, myopathy, inflammatory conditions of jaws, unspecified intracranial injury with loss of consciousness, states unknown, subsequent encounter, puncture wound without foreign body of pharynx and cervical esophagus, subsequent encounter for attention to tracheostomy and ventilation, unspecified, lack of coordination, abnormal posture, muscle weakness, generalized. And then history of present illness. The patient with chronic respiratory failure with tracheostomy and ventilation dependency. The patient has history of a cervical spine injury. The patient does have a PEG tube in place. The patient with a history of anoxic brain injury, dysphagia, critical illness, myopathy, neurogenic bladder, quadriplegia, convulsions, and bradycardia. The patient is currently lying in bed with a tracheostomy and ventilation. Family is at the bedside and the patient is minimally responsive. Doesn't respond to verbal or tactile stimuli at this time. Recently admitted to our ICU after discharge from another ICU to be closer to family. White cell count is 8.9 within normal limits. Sodium is 134. All other labs are within normal limits. Kebra level was 35.48. Therapeutic TSH is 0.13. We will monitor this closely. No fever, no chills. Again, minimally responsive pupils are sluggish. It's being followed by pulmonary and respiratory and wound care. Does have sacral wound area wound with wound back in place. We will monitor closely. So, those are all conditions that can be looked after at home with intensive care at home with ventilation and tracheostomy plus minus, either ventilation plus minus tracheostomy or tracheostomy plus minus ventilation, can all be done with 24-hour critical care nurses. So those patients do not need to occupy a critical care bed unnecessarily, right? So let's go to other questions. And you can find out more information at intensivecareathome.com. Like I said, with Intensive Care at Home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are the only service in Australia that is third-party accredited for Intensive Care at Home. We're also providing level 2 and level 3 NDA support coordination, right? So let's go to another question that has just come in overnight, where Cassandra asks, the ICU wants to make my sister a DNR. DNR stands for do not resuscitate. She's not brain dead. My family is outvoting me. I need information to persuade them otherwise. Thank you. Well, that is a tricky situation. The hospital cannot make your sister just DNR without patient or family consent. It sounds to me like your sister may not be in a position to give consent or refuse consent herself. However, then the next of kin or power of attorney or guardian should make that decision. And if there's, no clarity who's the next of kin or guardian, someone needs to take charge. But, the reality is that if you do agree to a DNR, that is, from my extensive experience, not a good situation, because the hospital will wind down treatment straight away because they don't see, the need to continue treating anymore. It's sort of, if you agree to a DNR, it's sort of the silent agreement that you no longer want treatment, right? That's what I've seen. It's sort of, if someone has a DNR, then the health professionals will say, oh yeah, we've got a DNR now and we're not going to do anything here anyway. It's almost like patients are written off, right? And that's simply not a good situation to be in, right? So let's go to other questions that have come in during the week. And if you have any questions, type them into the chat pad so I can answer them here, or join me live on the StreamYard link and I will answer your questions anyway. Right? So let's get on to the next question. That has come in from, oh yeah, it was actually a comment from on one of my YouTube channels with the title of one of my YouTube videos with the title of 10 common problems coming off the ventilator in ICU and how to overcome them. And then I had an email from Panda Bear My Cat. Thank you. You have helped me with your advice the other day. That's fantastic. That's what we want. And the same comment for this video is from Brenda, who says, thank you for your thorough, complete and easy to understand explanation of reasons to come off intubation. I am now in the hospital with my 92-year-old mum. Right, so that's great. Thank you so much for your feedback here. Then there is another question from Marco, who says, hi Patrick, my name is Marco and my fiance had heart surgery 3 days ago. She had a heart valve repair. She has not been able to wake up for 3 days. She was transferred to the ICU and they say that there's no brain damage and that she's breathing on her own, no ventilator. Can you tell me something more? Is a situation like this serious? Well, that's a good question, Marco. So let's break this down. The good news is your fiance is not on a ventilator. That is the good news, right? But she's not waking up, which I find very strange, that given she's not waking up, she's not on a ventilator. You know, can she protect her airway if she's not waking up? That would be a concern here, or could be a concern, right? You got to ask those questions. So if she has no brain damage, how do they know? Have they done a CT scan, an MRI scan of the brain? Have they done an EEG of the brain? How do they know she's not brain dead, right? She's not brain dead. She's got no brain damage. How do they know? How do you assess that she doesn't have any brain damage? Is she responding? What is she doing, right? So here's my theory. What might have happened here. Once again, I've worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years and where I've been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. So she probably had some complications from the heart valve repair, such as maybe extensive bleeding, maybe a cardiac tamponade, maybe arrhythmias, right? Atrial fibrillation, or worse, like SVT, VT, maybe even VTAC. Maybe she had a minor cardiac arrest. I don't know. But something didn't go straight forward after the valve repair. That's what it looks like. Also, is she on a lot of opiates, such as morphine, endone, fentanyl, to manage pain? At the end of the day, open heart surgery is extremely painful. Someone's cracking open the chest, right? That is extremely painful. And then patients after surgery end up using a lot of pain relief, like morphine, fentanyl, endone, oxycodone, OxyContin, right? And that could also make your fiance drowsy. It could, right? So also, does she still have chest drains in from the surgery? And if she does have chest drains in, is she still draining fluids or blood there? And are the chest drains so painful that she still needs pain relief, making her drowsy? Right? Those are the questions that I would be asking if I was you. Look for those things, whether, you know, those things are actually happening. Okay, let's get on to the next question. And if you have any questions, type them into the chat pad or contact me live here on the StreamYard link by clicking on the link. So the next question comes from Vegas, who says, "Hi Patrick, no, not from, that's the email. My name is Destiny. My father is currently in the hospital for cardiac arrest without oxygen for 45 minutes. It's been a month. He hasn't given me a thumbs up or wiggled his toes. They say he'll be a vegetable, so they recommend DNR on the medical report, but we told them we don't want him on the DNR list, so the insurance is denying his care and facilities." So let me read that again. My name is Destiny. Hi Patrick, my name is Destiny. My father is currently in the hospital for cardiac arrest without oxygen for 45 minutes. It's been a month. He hasn't given a thumbs up or wiggled his toes. They said he'll be a vegetable, so they recommend a DNR on the medical report, but we told them we don't want him on the DNR list. So the insurance is denying his and facilities. The last sentence doesn't make sense. Besides that, you are saying you don't want him on the DNR, which makes perfect sense, and you shouldn't be worried about that. Also, I find it repelling when hospitals say, or when hospitals label a patient as a vegetable. I repel that with all of my core. That is dehumanizing. As far as I'm concerned, humans are humans. They're not vegetables, right? Just my take on this, right? So if he hasn't woken up, right, and they want him DNR, that is the first step towards him dying, because they will wind down treatment. That's why I'm so opposed to DNRs, right? It's the okay for hospitals to wind things down, as far as I'm concerned, right? So you told them you don't want him on the DNR list. That's fair enough. That makes a lot of sense. So the insurance is denying. I don't know what the insurance is denying. That I don't know. That I can't make sense out of it. If he's not giving you thumbs up or wiggling his toes, that is definitely a concern. You should check his GCS, his Glasgow Coma Scale. You can type into Google Glasgow Coma Scale. You can assess his Glasgow Coma Scale yourself. It's a neurological assessment tool, and that'll sort of give you an indication of where he's at. The lowest GCS of someone who is completely unconscious is a 3, and the highest GCS is a 15. So, when I am a GCS 15, Glasgow Coma Scale 15, I'm awake, I'm alert, I'm oriented, right? That is what a Glasgow Coma Scale of 15 is. But your dad is far away from that. In any case, it ties in with today's topic, why families in intensive care have the perception that intensive care teams withdraw treatment prematurely. That's exactly what's happening here. Your dad is a month into cardiac arrest and an anoxic brain injury or a hypoxic brain injury. One could argue, some people might say, well, if he's not woken up, then we should start talking about end of life. Well, other people might say, well, if he's not woken up, it just means he hasn't woken up, it just needs more time, right? Probably the CT or MRI scan of the brain or EEG of the brain may suggest it's irreversible brain damage, right? And maybe it is irreversible. The question that you need to ask, what do you want for your dad? What would your dad want if he could make the decision himself? Would he want to live? Would he want to die? What would he want? Right? You have to think about that. But the bottom line is this: if you withdraw treatment, you know the outcome. You know the outcome if you withdraw treatment. If you continue, you give him a chance. You don't know the outcome. Right? Which one do you want to pursue? Do you want to keep going? Give your dad a chance? It is not a question of right or wrong. It is a question, what do you want for your dad? What would your dad want if he could make the decision himself? That is the question here. It is not a judgment question, right? You have to think things through very carefully. But one thing that I always advise is make a decision today that you don't regret in 12 months' time. If you make a decision today to withdraw treatment from your dad, right, you might regret that in 12 months' time. You might have second thoughts. You might think, what if? You might think, what if? That's what you need to think about, right? But don't let anyone coerce you to stop treatment or do a DNR if you don't want that. Don't do that, right? So we are going to wrap this up in a minute, right? With intensive care. And look, if you like what we're doing here, what I'm doing here, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button. If you find this video valuable, click the like button, click the notification bell, and share this video with your friends and families, and comment below what you want to see next, what questions and insights you have. It's really important that you do that so I can create the content that you want, right? Can feed you with the information that you want, that you are interested in, right? And that's also why we created a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. In the membership, you also have exclusive access to 21 ebooks and 21 videos that I've personally written and recorded, making sure you make informed decisions, have peace of mind, control, power, influence, so that your loved one gets best care and treatment always. I also, we have helped hundreds of members and clients over the years, improving their lives instantly when they have a loved one critically ill in intensive care. And we've also helped so many families in intensive care taking their loved ones home with intensive care at home now. You can find more information at intensivecareathome.com. I also do one-on-one consulting over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you simply can't afford to get wrong, right? I also talk to doctors and nurses directly, and when I talk to doctors and nurses directly on your behalf or with you, I ask all the questions that you haven't even considered asking but must be asked when you have a loved one critically ill in intensive care. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send an email to support@intensivecarehotline.com with your questions. Like I said, if you like my videos, subscribe to my YouTube channel, click the like button, notification bell, and leave comments and share the video. And like I said, I also do a weekly YouTube live like today, and you will get notification for the YouTube live if you are a subscriber to my YouTube channel or if you are a subscriber to my email newsletter at intensivecarehotline.com. With intensive care at home, like I said, we are sending critical care nurses into the home, predominantly for long-term ventilation and tracheostomy, home TPN, home IV potassium infusion. We're also sending critical care nurses into the home for bypass emergency services, which means we can cut the cost of emergency admissions by $2,000 by keeping them home and do the emergency service at home. Win-win situation. And for the ICU bed, we're cutting the cost of the ICU bed by approximately 50%. Let that sink in. We're also doing level 2 and level 3 NDIS support coordination, TAC case management in Victoria, and also WorkSafe case management in Victoria. We are NIISQ accredited in Queensland, ICARE in New South Wales, DVA all around the country. We've also received funding through public hospitals, departments of health, private health funds. So I am going to wrap this up here now. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com, and I will talk to you in a few days. Take care.